A warm welcome back from lunch, and hello from me. My name's Annette. I work at the National Institutes of Health Clinical Center Department of Bioethics. I'm also cross-appointed at the Fogarty International Center where Barbara Sina works, and I'm going to be moderating this session and had the great pleasure to work with three wonderful speakers today, actually alongside Joe Millam. We heard a lot in previous sessions about research priority setting at the national level. We heard from Uganda, Peru, India, Ethiopia, Tanzania, the Philippines, Zambia, South Africa. I'm sure I've missed some countries. We heard about different scopes of priority setting at the disease level, at the population level, when we were speaking about rural populations. We heard about different methodologies being used at the national level. We also heard from funders in yesterday afternoon's panel, EDCPP, SARC, NIH, and Wellcome. And today, in this session, the focus is really going to be on setting priorities at the level of research projects, research collaborations, research institutions, and especially in the context of collaborations between researchers from low middle income countries and high income countries on projects that are being conducted in low middle income countries. And the overarching theme, as I see it, for this session is that even when actors in those collaborations are really well-intentioned, it is often difficult to ensure that research projects are responsive to local health needs and priorities in low middle income countries. And we're taking a closer look at that. So we've got three people coming up, two presentations that I would say speak about sort of power imbalances in collaborations due to inequities in financial and academic resources. And we heard a lot about in our discussions where those are coming from, reflecting colonial histories, power imbalances in the current world order, and so on. One presentation is really going to look at how research collaborations can fail to address research priorities in low middle income countries, even when the stated goal is to promote local health and health equity. That's David's presentation, and Starlin is going to speak about how health institutions in low middle income countries might have difficulty adhering to their own research priorities, so they might have priorities when they enter into research collaborations. And then the third presentation by John is more focused on sort of a lack of ethical clarity on large collaborative research projects and how what he calls sort of the deliverability of intervention sometimes is overlooked as a criterion when we're thinking about which projects to pursue. So with that in mind, I actually want to call up the first speaker, who is David and Nderitu Wanjeri from Egerton University in Kenya, to speak about the US-Kenya partnership, a model north-south unequal friendship in health research, where balanced priority setting remains but a mirage. We will take questions at the level of the panel discussion, so we'll just have the three presentations, so maybe that allows you to also make some connections between the talks. David, the floor is yours.
Thank you, Annette. My name is David Nderitu Wanjeri from Egerton University. My background is philosophy, and today I'm going to share with you this topic, and I will say that priority setting remains but a mirage, but not entirely, as we are going to see in one of the examples from the partnership that I've used as a case. And I would want to appreciate a person that played a major role in this work, Eunice Kamara from Moi University, who guided me through this work, and we had a publication where I have plugged this specific argument. This research is based on this discussion is based on a research that I carried out back in 2017, and the main argument was that there is a global north-south relationship, partnership in Kenya, and it's largely coming out as a form of unequal friendship friendship among unequal parties from the Aristotelian point of view, because as a philosopher, I was just doing a critical analysis of the Aristotelian concept of friendship among unequal parties in the context of IU-Kenya partnership. Now, you'll find this concept in the Nicomachean Ethics for those philosophers who are here, book 8 and book 9, talking specifically about the friendship among unequal party. And the inequality is based on the fact that we have a superior party and an inferior party. And this one is based on the contributions and expectations of each party. And for that matter, a superior party is the one whose contribution is tangible, and in turn, the expectations are immaterial gains, for example, honor and pride. And on the other hand, the inferior party is the one whose contribution is always immaterial, for example, respect and loyalty, and the expectation will always be material. And for that matter, I wanted to see whether this partnership is, in this partnership, who is superior and who is inferior. This partnership is popularly known as the IU-Kenya partnership. IU stands for Indiana University, and I know that there's so many people in this hall who are familiar with this partnership. And it's a partnership that began over 3 decades ago as a collaboration between medical schools in Indiana University and Moi University and Moi Teaching and Referral Hospital, which is a national hospital in Kenya. And the main aim was to primarily improve the health situation in Kenya through a tripartite related mission of education, research, and clinical service. But now, 3 decades after, it includes several schools at Moi University College of Health Sciences and Moi Teaching and Referral Hospital on one hand, and a consortium of 11 institutions in North America, mainly in Canada and the US. Some of you seated here are part of this collaboration. Talking about the IU-Kenya partnership. So the main question in that research was, is the IU-Kenya partnership an equal friendship? Based on the components of contribution and gains, I found out that there are lots of benefits for different parties within this partnership. And this table summarizes the contribution and gains for each party. And you'll find that if you see there, Kenya, in terms of contribution, it provides ready field for research and population for research, which is basically immaterial, not tangible as such. And yet, it gains all that North America is giving, significant health institutions, all those ones, plus others which are not listed. It also provides millions of dollars in the form of funding to sustain the projects and the programs. Now, on the other hand, in terms of gain, Kenya will gain that one, but among the gains that North America gets is the pride and personal satisfaction for altruism, the good feeling when you are working with partners from Global South, but especially when you're working with the rural communities in Western Kenya. And therefore, that one brings out Kenya as, in the Aristotelian term, as the inferior party, and North America as the superior party. Now, according to the discussion that I had, and from literature review, this partnership has always strived for equity or equality, and also mutual benefit and mutual respect. And this is found in the standard operating procedures and the memoranda of understanding that these two sides of the partnership have had all along. And a very good example of how this partnership has strived for equity and equality and also mutual respect and mutual is through one of the most successful projects in this partnership. And in fact, it has become synonymous with the partnership called EMPATH, standing for Academic Model Providing Access to Healthcare. And within the project, they have a research network, which is co-led by partners from Kenya and North Africa. And this one refers to starting with the general directorship, then coming down to the course, and coming down to the specific areas of focus, and especially each and every project that is under this partnership. But despite all this, there still arises issues of inequalities. And my question, and these inequalities they're implied from some of the responses that I got from the research, and also the underlying discussions by the collaborators, but there's evidence in the description of all of the collaborators' work in the partnership. And now, the discussion that I'm having out of this is, does the inequality affect priority setting? This one led me to specific kind of challenges and practical challenges and also ethical challenges. And one of the issues that came up is that there is this perception that the global north partners or even institution is more competent compared to the Kenyan partners. And some of the respondents argued that the North American partners should lead because first, the global north provides the funds, and therefore it needs to have a bigger stake within the partnership in terms of the utilization of the fund and the areas and types of research. There's also an impression that the North American partners have better training in professional areas and research, and therefore they need to take precedence or they need to take lead. And then there was also an impression that the North America partners are more competent in grant writing compared to Kenyan partners, mainly because the lingua franca of research and science is English, and of course the North American partners have got that advantage, and also the exposure that they've had compared to the Kenyan partner. There's also a perception that there is laid-back attitude of the global South partners. It's a very serious allegation because according to some, they're saying that Kenyan partners assume multiple roles when they're coming into this partnership. At the same time, they are researchers, they're instructors at medical school or the College of Health Sciences. They are also physicians and consultants at the National Hospital, the Moi Teaching and Referral Hospital, and also their private clinics. And therefore, they do not have full concentration on research. This one leaves the North American partner at a very awkward position because they are coming into the partnership with a specific kind of description. They have what we call research faculty tracks. So they have to make these decisions because there are deadlines to be met and there's this fund to be utilized in the right way. So you find that because they're the ones who are left in the partnership, they have to make decisions. Some of them are not informed about the priority of the community where they're carrying out research. There's also an issue of where some Kenyan partners consider it a privilege working with the North American partners, and therefore they just relax. They pay less attention to the concerns about domination. As long as they are there, their name is there, and they've been included in publication, even when they just did some grammatical correction of the work, they are satisfied. And you know, this one now, it portrays the North America as dominating, yet sometimes that's what all they have to do for the sake of the project. Now, generally also there is the question about historical North-South inequalities in global health. And of course, this is something that has always been there, but it's changing. At first, global health was characterized by disease-specific. It was disease-specific. It was controlled by the donor. It was limited on social and structural determinants of health. And all those factors there, they sometimes do not address the priority, particularly for the community. And a very good example is empath. I've told you that empath stands for academic model providing access to healthcare. But initially, during the first years of the partnership, it was referred to, it was called academic model providing access to HIV and AIDS care, because the partnership mainly concentrated on HIV, because that is the time that HIV was ravaging Africa. So it was so specific. There is the whole question about paternalism in healthcare. There is lack of multidisciplinarity in approach to healthcare and research, and particularly in empath, where before the introduction of social research network and social behavioral and social sciences, these other health sectors were the ones that were dominating. Now, But there's been a lot of improvement in the last decade. The empath research has expanded beyond HIV/AIDS, and it includes other aspects of healthcare. And this one is attributable to the inclusion of diverse disciplines and the community input in the empath network. And obviously, this one will have impact on priority settings. These programs address broader dimensions of healthcare for the community, and therefore, it's promoting prioritization of the community. And that's why I said it's not entirely a mirage. Now, in conclusion, I will say that there is need, and this is my own personal opinion, there's need to readjust North-South health collaborations in due regard of power imbalance and contextual issues, particularly in the African context. And this one can be done specifically by building partnerships that are sensitive to this disparity, economic disparity, and strive towards empowering the inferior party. And this one includes research communities. And also it should be based on fair contribution and realistic expectation, especially from the North, from the South, Global South partners, and also promote the local research capacities. It should also engage multi and interdisciplinary and non-experts in health to broaden dimensions of community health needs, and therefore set the right priorities for local communities in research. Thank you. Asanteni.
Thank you so much, David. Please hold your questions for David until we have listened to the other presentations. I would like to call up Starlin Mythri to the podium, who is a physician working at Makunda Christian Leprosy and General Hospital in India, and who's going to talk to us about health research priorities in low-resource settings, perspective from rural northeast India. Thank you so much, Starlin.
Thank you. Oh, the other one. This is John's. Yeah. So, thank you for this opportunity, GFBR, and positioning myself. I'm a clinician working in rural Northeast India, and we work in a secondary level hospital, and then we also do research which is relevant to our healthcare provision. Okay. So there is dearth of data on how research prioritization happens in the rural areas, and then we at our secondary level hospital, we focus on maternal and child health because of the sheer numbers of maternal mortality, infant mortality, and things like that. But the focus is more on care provision, and then research is seen as something which is helping care provision and not as an individual separate entity. And then, so I present here our global health research collaboration and what happened and how in that. So it is coming from a perspective of a clinician and not a research institution. Okay, so this research project was mainly focused on doing a demographic surveillance of 150,000 people and a pregnancy cohort follow-up of 2,000 women. And we who are actually healthcare providers, I think you can understand in the context of how David was mentioning that we are not actually researchers, but then we are doing a regular job and then research on the side, and not much research capacity. So we were the implementers, we were the data collectors. And then there was this coordinating center at the national level, which had a lot of public health research experience. So they would help us with, guide us with data management, and then later analyze the big data which comes from this to create an algorithm and things. So the global funder plans to create a health pregnancy risk stratification algorithm, which will be used to create an AI tool, which also will be marketed, essentially to predict risk in predict maternal bad maternal outcomes, and also to suggest clinical way forward. So the AI tool might take something, the shape of like a tool which helps an insured mother in telling her how much risk she has, say, of developing a bad maternal outcome and things like that. So while this study was going on for the last 2 to 3 years, the ad hoc unplanned studies were added onto it. So one was that because we had this clinical material, that is the mothers in the research, we were asked to participate in a genomic study, which would validate another study, national study, to predict preterm births on the participants in this pregnancy cohort. And these two were aligned because operationally it was easy and expedient. And then the other unplanned thing which happened was suddenly we realized that we got a big package of some $85,000 worth of equipment, which was not there in the protocol, but then implicitly asking us to validate it on our participants, which were there in the demographic surveillance and other things. So such piggybacking studies, though economical in the economic sense, but then they complicate how research prioritization happens and how research is done. Now, we could not meet data quality standards towards the end of the study. For obvious reasons, we didn't have qualified data collectors, we didn't have training programs, we ourselves were not kept, we didn't have a research capacity. So then, so there was this stalemate where we negotiated somehow to be part of an interventional study for anemia in pregnancy, which made more clinical sense for us. And but then now the issue is about the future of this research is uncertain and without any clear plan. So when I look at partnerships like Kenya, which David presented, over 30 years, that didn't seem to happen in our case, which leads to an unsustainable research environment. So the ethical issues first is about the priorities and the purpose of research as to, because in our case, it seemed to us that the focus was more on developing technological solutions, which, as we know, perpetuate the injustices, because even if this AI tool is so cheap that it can be a free app on the mobile phone or things like that, but then who will give access to smartphone for a poor woman in the village, And so it kind of is modeled so that people with money, with living in the cities, urban groups, they benefit more than the people who are contributing the data. And then the second issue, especially from the demographic surveillance, is that we are taking this big data, which is very granular about everything, and then it might lead to social risks. One example being some of the governments in some parts of India were targeting minorities. And then when we went again to collect data, we were seen as people who are giving the data to the government. And then that created a mistrust because there is so much of data. A lot of data from one person over years. And then thinking about the health benefits for the participants, all these 150,000 people or the 2,000 or 3,000 pregnant women seem very minimal. Now, I'm a little suspicious of this word global north and global south. Maybe it's local north and local south, or or combinations of that, because that makes things very generalized. It doesn't give a face or a thing to the relationship. So it's, as David mentioned, unequal relationships, unsustainable research. So the recommendations from this is what everyone has spoken. I think the focus should be more on a dialogic, reciprocal relationship than one-sided relationship. And then, in our case, though we had a research priority for maternal and child health to prevent or to address the bad outcomes, we didn't think it through as to what solutions might be useful for that. But when the funder came with a technological solution, we were not aware that it might not be the best solution for our, a priority solution for our population. So we learned that it is important that, as Joe was saying in the keynote address, that prioritization has to happen also on the solution end, not just on the question or topic. And then as in our case, which might be a rare or a rare occurrence, that when research is sustained over years, I think that's more ethically just than research which is done as one short-term research for a particular end to receive data and things. The third thing, I think, because this is purely from a clinician perspective, I think the focus should be that individuals and populations are the priority and not just abstract entities about priorities. And then from this perspective, thinking also from the validation studies that were asked to be done, I think something which was not considered is that health care prioritization should go hand in hand with health research prioritization. So when we de-link in one of our breakout groups, we were discussing that there is an association of healthcare prioritization which doesn't talk to health research prioritization. So there are these two streams which on the ground are so much together but are not discussed even in forums like this. So I think John presenting after me also links to this. And then, so the whole question about accountability of who will hold global funders or anyone in this whole, so how can we make it more accountable, more transparent? So thank you. I would like to thank my, so this is a presentation not just from me, this is a presentation from our hospital research committee, whom I'm representing here. And I'd like to thank Dr. Vijayanand, who gave some comments from India, especially Joe and Annette, who helped us a lot to structure this presentation. Thank you.
Excellent. So the last speaker on this for this session is John Baruhagaru, who's a philosopher from Makere University in Uganda. And he's going to speak to us about the deliverability of interventions as a criterion and priority setting for health research, the case of H3 Africa, and gene-based interventions. John.
Thank you, Annette, and good afternoon to you all. I've been introduced, and the title of my presentation is Deliverability of Interventions as a Criterion in Priority Setting for Health Research, and I'm going to reflect on the case study of H3 Africa and gene-based interventions. Well, if you ask me an alternative title for my talk, I would call it Pathways and Barriers to Optimal and Timely Social Value for Research. Ultimately, we know that we care about appropriate priority setting in research because we realize that we need to achieve social value using scarce resources. But my observation has been that we normally take these pathways and barriers to social research for granted. We tend to operate with the assumption that once you identify a population that is mostly needy, and then you identify the most pressing health needs, you design a study, get the data, develop interventions, and they get licensed. We tend to think that that automatically will lead to social value. But my presentation will be intended to demonstrate that this is not always the case, and therefore we need to pay keen attention to the pathways and barriers to social value in research. So the criterion to be defended for inclusion in priority setting for research, health research rather, is the following. It is, says that all things being equal, the higher the likelihood that a proposed intervention will be widely delivered to those who need it, and the sooner it will be delivered, the higher the priority it should be assigned. And this is proposed in the following context. We know that comparatively, when you look at sub-Saharan Africa and other low and middle income countries, they have relatively lower health opportunities, and this affects their health outcomes, which are correspondingly low. And because of this realization, it led to the vision of optimizing health outcomes and reducing disparities through research by setting clear priorities and those which are appropriate. It is a strategy for reducing these disparities. Of course, there is some criteria as indicated in the background paper and ably presented by Joe yesterday, that is currently being used by researchers to set priorities for research. However, when you look at these criteria, they have, there is something missing in them. And what is missing is because of the assumption, which as I mentioned earlier, that once you produce certain interventions which are needed, then they will automatically translate into social value. So generally my presentation, rather this criterion I'm proposing is based on the following claim or assumption, that the social value of research is better realized the easier it is to widely deliver the researched and developed interventions to those who need them. And that's how I come up with this particular criterion. And I'm going to illustrate this using the case of H3 Africa and the likelihood of developing gene-based interventions for Africa. Now, So, there has been a consortium going on in Africa called Human Heredity and Health in Africa Consortium, and it has generated considerable data, and I'm told it is closing. But what we know is that at the end of the day, this data is going to be leveraged to innovate and develop interventions, and of course, these are going to be gene-based interventions. I think there seems to be a slide missing there. But what you realize is that once you develop these interventions, the most important thing is, will they be easy to deliver within Africa? Talking about the deliverability of interventions, this can be demonstrated using the concept of conversion factors. Generally, the concept of conversion factors means conditions that determine the possibility, feasibility, and ease of deriving utility from a given good. This can be a health good in the form of interventions that may be developed. This should be understood as some of the necessary conditions if a given health intervention is going to be effectively delivered in a given community. And I use this example of a bicycle to demonstrate my case. Usually, when you have a bicycle, it is an opportunity for you to move faster from one place to another. But it does not always follow that once everybody that has that bicycle is going to be able to move faster from one place to another. For someone to take advantage of this bicycle to move faster, they will need a riding skill, they will need a favorable built environment, and they will need favorable cultures, for example, cultures that do not forbid, for example, women from riding bicycles. Once you have a bicycle and then you don't have these factors, you cannot translate the bicycle into the utility of moving faster to your destination. And this applies to health interventions. Health interventions have specific characteristics that must be borne into mind and taken into consideration when you are designing and developing interventions for certain populations. And some of these rather characteristics of interventions are to do with the technology, what type of technology do they need for them to be delivered in given contexts. Then the physical infrastructure, especially, for example, special storage conditions that may be required to store certain vaccines or other things that need to be used, and even skill sets that are required to deliver those interventions. So the point here is that you can develop interventions, very effective, targeting the right communities, targeting the right diseases, but once you find that those interventions cannot be delivered to those communities because of the mismatch between the characteristics of the interventions and what are the conditions that exist in those communities, it will not be possible to derive social value or to optimize social value from those interventions. Now, this is the case of H3 Africa. Now, I mentioned that H3 Africa has been going on for some years and it's coming to an end. This has been a purely research enterprise, just collecting data. But we hope that at the end of the day, this data is going to be used to innovate and produce gene-based interventions intended to address the health needs of people within Africa and other communities. But the concern about these interventions have been raised. One of them is the risk of deepening health inequities. And Harrison and colleague have mentioned something to do with the problem of ensuring that these sustainable medical advances can be fairly and equitably delivered to desperate patients and families. And some other people have talked about the likelihood of these interventions remaining inaccessible to the majority of the people in low and middle income countries for a long time. And when you look at these studies, they are emphasizing the characteristics of the interventions and how their characteristics are likely to be an obstacle to their implementation in those communities. Now, I'm going to use an example of the gene expert machine in Uganda. During COVID-19, we were sitting, we were beginning a meeting in a research ethics committee. Then we had a story. It was a story in the papers that one of the gene expert machines had lay in a hospital somewhere in rural Uganda for a whole year without being used. And then it sounded like a funny story. And someone was asking, why was that the case? Someone was saying, no, there is no power, there was no one to operate it. So at that point, I started thinking, what was the importance of that machine? And then along the way, I realized that a number of studies in the hospital research ethics committee were trying to modify certain interventions which are technological based, to modify them to suit Ugandan conditions so that they can be effectively used even in rural Uganda. I stayed with this until there was a call for this. I said, I have the time to talk about this issue. So when you look at the way the gene expert machine is described by the WHO, it makes you realize that actually this is a low-tech kind of intervention. It should be easy to deliver almost in every part of the world. But even though that is the case, you realize that in a country like Uganda, it has not been easy because of low access to electricity and the need for refrigeration services, which are quite rare in rural Uganda, and other conditions that are needed for its effective implementation. Now, what do we learn from this as H3 African generally for research priority setting? My view is that in thinking about how to take forward H3 Africa project, especially if the researchers are going to use the data generated to develop interventions, they should bear the question of how easy to deliver with the interventions from H3 Africa Consortium data be in Africa, especially if the research and development is going to target diseases that affect people in Africa. Then those who will use this data to develop interventions to benefit people in Africa must bear in mind the conditions within Africa that are going to be sort of mediating conditions between the availability of a good and its ability to be implemented within communities to generate the social value that is being targeted. Generally, these are points of emphasis. I'm calling this criterion of deliverability a complementary criterion. It is not meant to replace any of the existing criteria, but say that once you have got all these criteria right and you produce the interventions, you should ask, of all these proposed interventions to be researched, which one among them is going to be effectively delivered and in the short run, okay? Of course, the example I have chosen of the gene expert machine may not be the ideal one, but the most important thing, the essence of the case, is to illustrate the value of the deliverability criterion for optimal social value and equity, and then the concept of conversion factors in implementing this criterion. In my conclusion, I'll say that in absence of appropriate conversion factors, health interventions remain mere potential health opportunities as opposed to real opportunities. And in that case, you cannot think about optimizing social value. And from the point of view of equity, it matters how long a certain group of people wait to access certain intervention, which is already being accessed elsewhere. And my recommendation is that we need to adopt the deliverability criterion and study its current impact on health equity. Thank you.